Oh,
Okay, so I think that I'm just starting today. Um, I'm Katie, practice nurse in Sheffield and practice nurse educator for the ICB at the moment. Um, I think Gary's just letting everybody in gradually to the meeting, but hopefully we can just get started in a minute. Natalie, who put the meeting on, assured me that everybody had received an email this morning with the agenda, housekeeping, etc. on it. So hopefully that all makes sense to you all. Um, for our talk, if you want to put questions in the chat, then hopefully James and Farah can just monitor the chat for me, and or you can unmute at the end and we can answer questions then. Um, the theme of this afternoon's PLI is referrals, apparently, but I'm afraid mine isn't particularly about referrals. We're talking about the T2DAY program for young adults with type 2 diabetes. So I'll just share my screen. Okay. So, James, can you just give me a thumbs up if you can see that okay? Great, thanks. So yeah, we're going to talk to you today a little bit about the T2DAY project, which is an NHS England project actually nationwide to improve the care and outcomes of younger adults with type 2 diabetes. Um, I'm going to be talking, and James and Farah are going to be also talking to you. That's just a little bit of housekeeping. Just try and keep your microphones muted if you can, and then we won't get any like feedback or anything. So we're going to talk about the programme and the current situation in South Yorkshire. We're going to talk about preconception and pregnancy care for young adults with type 2 diabetes, improving access to the prevention and remission programmes. Farah's going to talk a bit about the Foundry pilot project for improving the care of these patients and what you can do to improve the care of your young adults with type 2. So just to put things in perspective a little bit, this is a slide of Lisa Wilkins, who's public health consultant in Sheffield, which I think is just quite brings it home really the size of the problem with diabetes in general at the moment, and in young people are no exception. So if we just look at these figures, we can see that since 2010, our QOF registers for type 2 diabetes have increased by 72%. So that is probably explains why we all feel a little bit overwhelmed with the number of diabetic reviews that we're doing, because these numbers are increasing really quickly. 1,000 more people in South Yorkshire are being newly diagnosed with type 2 each year compared to 10 years ago. And we've got 11.5% of the population now with non-diabetic hyperglycemia, so, otherwise known as pre-diabetes. We've also got an increasing number of women with gestational diabetes, who are therefore then at risk of going on to develop type 2, which we'll talk a little bit about later. So early onset type 2 diabetes, just a few sort of key facts. As I've mentioned, it's an NHS England 2-year initiative to improve the care of these people, patients aged between 18 and 39 with type 2 diagnosis. Um, any sort of diagnosis under the age of 40 years of type 2 is defined as early onset. And it's more common in people from ethnic minorities and people that live in socio-economically deprived areas. So these people are already at risk of huge health inequalities. It's just an additional problem there. The high proportion of the people with early onset type 2 are living with obesity, and they'll often have unmet psychological and social needs as well. So our team and the T2DAY team at the ICB comprises Natalie, who's a specialist midwife who unfortunately couldn't be here today, myself, practice nurse, James and Farah, who are both health and wellbeing coaches, Annie, who's our program manager, and Amy, who's our project implementation officer. Those are our contact details if you want to contact us for any more information after this talk today. So in case you're wondering why do we need to focus on younger adults with type 2 diabetes, I'm going to tell you. So early onset type 2 is associated with a more aggressive diabetes phenotype than when people get it when they're older. They're likely to have a more rapid progression of their glycemia, more likely to have an early development of diabetes-related complications. So that's the microvascular and macrovascular things that can go wrong, the eye damage, kidney damage, amputations, heart disease. And they also have a significant reduction in their life expectancy. There's an increased risk of adverse maternal and neonatal outcomes for the women of childbearing age who are not prepared for pregnancy adequately. And we could talk about a little bit about that later. So this reduction in life expectancy is a real key point. If somebody's diagnosed at 45 years of age, which is actually above this cohort that we're talking about, they've got 6 years less life expectancy, which when you compare sort of dying at 80 to dying at 74, is really quite significant. I mean, any reduction in life expectancy is significant, but when you think of it like that, it kind of sinks home a little bit. Women with type 2 diabetes, the number under 40 is growing. And now 54% of pregnancies in people with diabetes, well, 2 years ago when they took the figures in, related to people with type 2 diabetes. So this is a doubling in proportion of this cohort since 2002. Getting an HbA1c below 48 millimoles is really key for getting good neonatal outcomes. But unfortunately, the number of people achieving this level in their HbA1c in the 2020 figures was only 11% of women with type 2 diabetes. And then it's an even lower percentage if you look at those living in the most deprived areas. Sorry. So the situation in South Yorkshire at the moment, when we're thinking about whether these patients get their key care processes completed, which you'll all be very familiar with, the figures are very, very low. So if we're looking at how many patients, what proportion of patients have 8 of their key care processes completed, and I'll just pop back and just remind you, I'm sure you all know this, but this is the albumin, creatinine level, smoking status, blood pressure, HbA1c, serum creatinine, serum cholesterol, weight and BMI, foot check, and eye screening. So the really basic diabetes care. People getting all 9 of those in South Yorkshire, in the data taken from October, was only 15% in this younger age group. Even if we look at how many are getting 8 done, it's still only 26%. So the National Diabetes Audit data from 22-23 shows us that we've got 3,600 individuals with early onset type 2 diabetes. And of course, the majority of these are cared for exclusively in general practice. These patients are generally not under a specialist diabetes nurse. So this is our role basically in our job. The prevalence is increasing yearly. And patients with early onset type 2 in South Yorkshire has increased by 148 in just 4 months, the last time we took a snapshot of the data. So we can see that this is a tsunami coming, basically. Not only is type 2 diabetes rising really quickly, these younger patients with type 2 are rising really quickly, the most quickly of all people with type 2. So despite all the risks, people with early onset type 2 are actually less likely to receive their NICE recommended care processes and tend to have a higher HbA1c than the older people with type 2 diabetes. So our project, the T2DAY project for the ICB, has been looking at prevention of diabetes, looking at integration of care between secondary and primary care, voluntary and community organisations. We're looking at engagement and education, both of clinicians and of patients. And we're looking at the remission programme and how to make the most of that remission programme for our patients. Yeah, these are Natalie's slides, who's a specialist midwife, but unfortunately she's not here, so I'll go through them today. So I'm not an expert, obviously, on maternity things, but I do know the basics, and if there's any tricky questions, I can pass them on to Natalie. So thinking about how to prepare a woman of childbearing age with type 2 diabetes for pregnancy, they obviously still need to have all their 9 key care processes, and this is vitally important that they're up to date with these. Then also there's some additional things that are in the NICE guidelines. It's all absolute basic care, but it's sometimes things that sort of slip through the net for one reason or another. So these women can actually, according to NICE, have a monthly HbA1c if they're contemplating, if they're actively wanting to plan conception. And this is just so they can keep a closer eye, and the clinicians can keep a closer eye on their HbA1c and see if they're getting closer to target. They should obviously have contraception advice and initiation if they're not planning on getting pregnant, and that is vitally important. They will need, if they're planning pregnancy, they'll need a higher dose of folic acid than non-diabetic women are advised to take. So this is 5 milligrams of folic acid, which is prescription only. And this is to reduce the risk of neural tube defects and assist, with the baby's development in the early weeks of pregnancy. So they should be taking this 12 weeks prior to pregnancy, preferably, and then into their pregnancy. They should be taking vitamin D, and that can be taken via an over-the-counter pregnancy vitamin. But the folic acid in the over-the-counter is not enough for somebody with type 2 diabetes. They should also be offered glucose monitoring as well if they want it. So Natalie has just put this little reminder of all the different contraception methods that they could use. There's no reason why they couldn't use any of these in most cases unless they've got other comorbidities. So the concerns around diabetes and pregnancy when somebody's got type 2 diabetes or any diabetes is that its risks to the actual woman include things like existing conditions worsening, preeclampsia, polyhydramnios, increased risk of diabetic ketoacidosis in the 3rd trimester, or if they need to use steroids, hypoglycemia unawareness, perineal trauma, and they're more at risk of induction of labour and caesarean section. And then the risks to the baby are that it's more likely to get admitted to a special care baby unit. It's at risk of heart defects and spinal defects. There's a higher risk of miscarriage, higher risk of large baby and birth injury related to this, higher risk of stillbirth, hypoglycemia in the baby, and also they're at risk of obesity and diabetes later in their own lives if their mums had type 2 diabetes and not been well controlled. So Natalie just popped this on to show you that the proportion of women presenting who have diabetes, presenting pregnant and the most recent figures, there's more women with type 2 now who are pregnant than with type 1 in the whole diabetes category. So they've kind of overtaken the women with type 1 that are presenting in antenatal clinic. And then concurrent to this, if you compare year on year, the women with type 2 are actually having more stillbirths. So people with type 2 diabetes, women, may not have likely not to have a diabetes specialist nurse. So obviously we again are in sole sort of responsibility and primary care to provide this preparation and make sure women are aware of these risks. All women with type 2 diabetes are entitled to preconception care, the same as a lady with type 1 would have. And the initiation of this preconception care will be with primary care and with practice nurses and the GPs. So once women are within range to have a safe pregnancy, so that's 48 or below ideally, then they can be referred to secondary care. Or if you're struggling, or if there's any problems, or if a woman's complex, then obviously you can refer them into secondary care. And women with additional medical conditions might need an early referral, obviously. So just a reminder that women who've had previous gestational diabetes are at risk, higher risk of developing type 2 within that 5 years after their diagnosis. It's really important that gestational diabetes is clearly recognised, clearly marked on the notes, and that primary care has got a handle on that and is going to be monitoring that. Advising primary care of the correct coding. This is what we're trying to do for secondary care, is to pass on the diagnosis and then the correct coding to primary care so that it can trigger us to do the recalls, referrals to the prevention programme, etc. So they should be getting these codes on their notes if they've had gestational diabetes diagnosed during a pregnancy. And this is coding, as we know, is all important for recalls and data gathering and good care. So referrals, these are the referrals for South Yorkshire if you needed to refer somebody by email, or there's a phone number for Sheffield. And also, Natalie put this in case anybody wants to maybe have this up as a poster or a leaflet or whatever in their practice, that women can actually self-refer if they find out they're pregnant, because ideally they should be seen before 10 weeks of pregnancy. But at any point, if there's some problem with the GP practice, then a woman can self-refer using these QR codes. So I'm going to hand over to James, and James, just tell me when you want the slides moving on. Thanks.
Will do. Cheers, Katie. Thank you. So my name is James. I'm the Diabetes Health and Wellbeing Coach. Also working on the T2DAY project, but worked a lot in Barnes in particular. So next slide, please, Katie. So I'm going to talk about the Diabetes Prevention Programme first. So hopefully you might have already heard about what this programme is and you're already referring in. So basically it's a 9-month programme. The first 4 sessions is every fortnight, and then it goes down to once a month. So 9 months, quite a long programme, but they're the topics there, what they go over each session with the patients that are eligible. Different options, so they can have face-to-face group options, they can do remote options. So this is for 4 priority groups. So like I just mentioned with the gestational diabetes, do one specific for women that have had gestational diabetes. This will be over like Teams like we're doing today, so a bit like that. They have one for different languages, people with hearing impairments, and I think that's all, yeah. And there's a digital app option as well. There's a link there to a website, so that'll tell you a bit more about what the programme is. And next slide, please. So eligibility criteria. So anyone aged 18 plus can go on this programme. HbA1c of 42 to 47. And can't have been diagnosed with type 2 diabetes in the past, and now into the remission stage, so they can't go on the programme there. They can't be pregnant when of referral, but like he mentioned with GDM, once they've had the baby and they've had gestational diabetes, they can go on the programme at any point, and their HbA1c don't have to be between 42 to 47, it could be in the normal range, but like Kate mentioned, they're more likely to get diabetes 5 years after being diagnosed, so trying to offer this programme as soon as possible to these ladies. And yeah, next slide, we don't need to cover the last one. Referral forms, hopefully you've seen the referral form before. It's quite simple, it's just one page. Most of it's auto-populated from the systems. So all it'd just be like your referral name and then ticking the boxes. HbA1c, so making sure it's done in the last 12 months. If it's a gestational diabetes patient, their HbA1c might be below that 42 to 47. So just make sure you tick the box where it says as previous gestational, just put yes and date the or diagnosed with that, just so it prevents it from being rejected, that's all. And then the email there is where you'd send the referral form. Same again, it should be on the systems for all this. But recently, the gestational diabetes patients, they can now self-refer into this programme. So by following that link there, we have created some posters. We can always send these out as well with QR code on. And with this self-referral for gestational diabetes, they don't need to know what their HbA1c was in the last 12 months. They can just self-refer. So it's quite a easier way or a quicker way for these women to refer into the programme. Next slide, please. So I'll just talk about the Path to Remission programme as well. So this is mainly for people with type 2 diabetes. Same again, you might have heard this. It used to be called the low-calorie diet. But they did a few pilot projects using the direct and droplet studies. And yeah, they changed the Path to Remission programme after they ran the studies. Found it were quite successful. Memento Newcastle have got the contract for South Yorkshire. So basically it's total diet replacement for the first 12 weeks. So this is going on shakes, soups and bars of 800 to 900 calories. And then after that, it will be the food reintroduction week for 6 weeks. So they'll be seeing a coach from Memento, either one-to-one or digital. And then after the 6 weeks of that weight maintenance, making sure that they're keeping on track, do they need further support, that kind of thing as well. It's all completely free for patients to go on, and they can choose which option they want, that one-to-one or digital. Next slide, please. So depending which option they choose, so if they choose the one-to-one, the big game, the booklet, the workbook, the trackers, the pedometer, recipe book, and then the coach would monitor the blood pressure, the weight, the blood glucose as well. But if they decide to do the digital pathway, they'd be sent some weighing scales, blood pressure and glucose monitoring machine, and strips, all completely free. So patients would receive them, monitor it themselves, input it into the app, and if at any point their blood glucose or blood pressure starts rising, the coach from Memento would refer them back to the GP because they may need to start medication. Because with this program as well, they may have to stop certain medication on day one of the program. So it does need a prescriber or a clinician to sign off these referrals as well. Next slide. So eligibility criteria is a bit more longer than the diabetes prevention program. But anyone aged 18 to 65 diagnosed with it within the last 6 years. BMI, obviously, above 27 or above 25 for the BAME origin. And HbA1c, main one to look out for is below 87. Anything above 87, they can't go on the program either. They can't be on insulin. They can't be currently breastfeeding or planning to get pregnant within 6 months. But there is a clinical search on the system, an Arden search, where I'll show you where to find this in a moment, but this should automatically pick all this inclusion-exclusion criteria up. All the things it probably won't pick up is obviously breastfeeding or planning to get pregnant. So there are some of the questions you might have to ask with the patients. Next slide. Referral form, so it's a bit longer than the diabetes prevention, so I think there's about 3 pages to it. Same again though, most of it does get auto-populated. So there's only a bit on the right-hand side, the referral form there, it'll say referrer's name, so that's where you need maybe a clinician to sign it off, or a prescriber, just so they're happy for that medication to stop. So it tells you medication just above there, so you just choose whichever the patient's on and if to stop or not stop. And on the last page, next slide please, Katie, is the medical adjustment form. So you click on where it says NA, it'd be like a drop-down box. It'd choose whatever type of medication they're on, and then action might be to stop, carry on taking, or it might be to reduce as well. And obviously this gets sent to the provider, so that email address at the bottom, but also the medical adjustment form would get sent to the patients, so patients are aware of what medication they need to stop or reduce, and make sure it's on day one of when they start the actual shakes and soups and not before. Next slide. Here's a case study of a patient that completed the first 12 weeks of the shakes, soups and bars. So he managed to lose 10.8 kilograms, which you'd expect going from 800 to 900 calories. Obviously his BMI came down with that. HbA1c, so you see it was 59 when he first started, now 46, so he's in like the pre-diabetes range, and hopefully that will carry on and go into the remission number as well. But then it had a really good positive impact on his cholesterol and lipids results. As you can see, his total went from 5.7 to 3.8. His triglycerides really came down from 5.45 to 1.85. So yeah, it's going to have these positive impacts, not just on weight, HbA1c, lipids. I spoke to another client the other day, it had an impact on a liver results and liver tests and that. So yeah, it's been really beneficial, this program, for some people. Next slide. So this is just how to run a clinical search, so for system 1 and EMIS. So just a little flow chart. So whichever system you're on, if you just followed this on your system, you'd be able to find eligible patients for either the diabetes prevention program or the path to remission. Just run that search, it takes a couple of minutes, and then it'll tell you all patients that are potentially eligible. Like I put in there, just please review some of the patients. So diabetes prevention program, I've not had any issues where people are not eligible for the program. The path to remission, you might just need to check some and try and find simple referrals for that one as well. So maybe them was just on metformin or newly diagnosed diabetes, try and offer them the program instead of being offered medication, that kind of thing as well. Next slide. So I created this Florey questionnaire. So I know Claire Thompson has done a bit of work as well in Sheffield with some practices already. So she's done a few Floreys too. So these are ones I created for diabetes prevention, one specific for GDM patients and one for path to remission. So there is a link here. I think we're sharing these slides, but you could click on it and it'll import straight to your AccuRx for your practice. You just might need to adjust it to fit Sheffield at the last page. But it's one way, just trying to see if it increases referrals. It's worked well in Barnsley, but we did try it with Farrow at Foundry. It didn't work that well at that one. So yeah, it's trial and error. You can try it. Next slide. So just some top tips to kind of finish with. So that search, what I've just mentioned with diabetes prevention, it will pick up your GDM patients in there. So if you do order it by gender or age, normally the younger females tend to that they've had previous gestational diabetes. So it might be just to double check, have they had gestational diabetes, which florey to send them. And like Katie mentioned, making sure they've got that recall on, they're having their HbA1c done annually, so make sure that's put on the system and they're coded correctly as well. And like I said, making sure you tick that GDM when you do the referral form. And I think that's the main bits for that one. Sending it forward to patients once they've had blood tests as well. I've seen this a few in practices where they may just get coded as borderline or satisfactory repeat in 6 months' time, but they're not either getting coded as non-diabetic hypoglycemia, they're not being offered diabetes prevention programs, so just making sure that's been done in practices too. And then the links there just for the self-referral for gestational and a bit more about what the program is. Path to remission, same again, just like I've mentioned before, identifying simple referrals, trying to maybe avoid blood pressure ones, of course. Depending on the blood pressure, they may have to stop medication on day one of the program. So if it's normal, they're on blood pressure medication solely for blood pressure, it's advised that to stop that medication. So that just gets a bit more complicated for prescribers and clinicians thinking what do they need to stop, what they need to reduce. So I try to avoid them patients to start with, just for simple ones. Same again, there's resources there. So top ones for referrers, there's a bit more information about deprescribing medication, a bit more about what the program is, and then there's a separate one just for patients. And next slide, I think that might be it. Yeah, I'll pass on to Farah now to talk about the work she's done in Foundry.
Thank you, James. Hi, everyone. I'm Farah, and I'm working on the type 2 diabetes in the young project, and it's primarily working within the Foundry PCN. So the question would be, why Foundry PCN? Next slide, please, Katie. So Foundry PCN, research studies indicate that type 2 diabetes is more common in people from ethnic minorities, particularly in people from the South Asian ethnicity and people living in the more socio-economically deprived areas. Foundry PCN has a total population of over 59,000 patients. The PCN has a widely diverse patient population, and 7 out of 8 practices are in the most deprived decile, decile 1, and the 8th being in decile 3. Now, there is a high number of type 2 patients across Foundry compared to other parts of Sheffield with low engagement with primary care. So in February 2024, we had 262 patients with type 2 diabetes, and only 35 of them had all 9 care processes. So that just builds up a little bit of a picture of the situation in terms of type 2 diabetes in Foundry. Next slide, please, Katie. So with this work being undertaken, we decided to have a pilot at Burn Surgery. So it was 3 Thursday mornings at the practice with 8 available clinic appointments on the day. So this was protected clinic time with pre-booked appointments, a very targeted approach using telephone calls to identify patients. So the practice nurse, the practice manager, and myself were involved with this pilot. So what worked really well was the coaching and education element to reduce DNAs. It allowed time to ask questions and address any concerns, and it took a very holistic approach. So we utilised other appointments for any of the elements that were missing, and we identified areas of priority that were missing. So for example, for Burn Group, we identified 3 key care processes were being missed in reviews. So the lessons learned was to know what services are available in the local area, for example, weight management, Carb Smart, Mulmore, Sheffield, and this allowed a very structured approach to appointments. So as an outcome of the pilot work at Burn Group Surgery, out of 24 appointments, 21 were used. So we had an 87.5% uptake within 3 weeks. So that saw, within 3 weeks, that saw a 3% rise in the key care processes and a 43% rise in the 9 key care processes. So next slide, please. This is just a little case study of how, the work as a health and wellbeing coach on the T2DAY program has evolved. So we had a patient who was 39 years old, moved to the UK 4 years ago and had changed his address 4 times. So he was diagnosed with type 2 diabetes in 2021 and had not had any of his key care processes met. There was a reluctance to accept his diagnosis. So there was lots of issues. There was an incorrect address on system 1. There was a very fractured relationship with the GP surgery. He worked nights. There was a 0-hour contract, poor eating patterns, didn't answer private calls, complex social issues, and housing was his priority. And he was living in a private shared accommodation with 10 people. So he had limited kitchen access to cook healthy foods and have that regular eating pattern. And he had concerns regarding his vision. So the approach was I had called the patient several times at different times of the day, and then I managed to get through and understand that his working routine allowed him to answer the phone in the afternoon or later periods of the day. So I provided an awareness around type 2 diabetes and the importance of annual reviews. At that point, the patient didn't care about his diabetes. The only support that he wanted was with housing. And then later I disclosed in that call that he was concerned about his diabetes, but housing was his priority. He agreed to book an appointment at a time that suited. An appointment was booked with myself, the care coordinator, and the nurse. So the outcome of that was the patient had attended his appointment, support was provided for housing, the address was updated, all 8 care processes were completed, and we also booked him in for the 9th key care process, that being retinal screening. And then we also discussed local services and online platforms that are accessible to him. So the key kind of message that I want to kind of emphasize here is, yes, it took us 3 years for him to attend, but it only took us 30 minutes to book. Next slide, please, Katie.
I think, Farah, might be... Oh, no, I did leave. I thought I'd cut this out. I'm glad I didn't.
Fine. So just some top tips. It's identifying patients and review the missing care elements to support conversations. Know what works for your patients at your surgery. Use interpreters. Know what services are available locally. Split your appointments where possible. Coding, retinal screening. Is there somebody that can support them, or sending out text messages just to remind non-responders? And then we just utilise any existing appointments that we have. And that brings us to the end of my presentation. Thank you, Kate.
Thanks, Farah. That's brilliant. I think it's really helpful with things like that case study to just make it be a bit more real, with an individual patient case study to see, because we realise, don't we, that although diabetes is top of our agenda when we're calling somebody for a diabetic review, it's definitely not the top of our patients' agenda a lot of the time. They've got a lot of other things going on, haven't they? So if we think about what we could be doing differently for these patients, obviously we need to actively seek out these patients, these younger type 2 diabetic patients, because as we can see from the figures, they're not seeking us out. We may well need to think differently when we're consulting with a younger person with type 2. They're going to have different kinds of priorities and responsibilities maybe than an older person, maybe a retired person. They might have a young family, they're probably working, etc. So a different way of thinking. Thinking about that when we're assessing things like the cardiovascular risk, it's just a note that a Q risk tool that is commonly used in primary care will actually underestimate the cardiovascular risk of an early onset type 2 person. Early onset type 2 plus any one additional risk factor equates to high cardiovascular risk. And I will just mention this again in a minute. Talk to them of childbearing age about the contraception and the risks if they're not prepared for pregnancy. If they have not got contraception, then theoretically they are aiming for conception. Question a diagnosis, maybe if it doesn't feel right. With these younger patients with type 2, there's always a chance, isn't there, that we've got a type 2 diagnosis but it's actually a type 1, or vice versa. So if things don't feel right, if it just doesn't seem right, or maybe they're not responding to the treatment how you'd expect, then just kind of question the diagnosis, question it yourself, refer if you need support, ask your GP, ask the specialist nurses, ask us for advice, but maybe just question it because it could be wrong. Promote self-management and remission, so using the type 2 diabetes remission program to anybody who's eligible. And then we've got the Desmond, the Healthy Living for type 2, expert programs, different things in different areas, but there are a load of different resources that we can utilise if we want to. And then we'll obviously encourage people to promote the prevention program to anybody who's eligible and interested. And remembering that all women with a history of gestational diabetes are eligible for the prevention program, whatever their HbA1c is now, because they're at high risk. So what support is available for us when we're looking after these patients? We've got a monthly educational lunch and learn session. It's been running all this year and it's going till April next year. You'll get this on the bulletins and on the circulars that come round. We've got a diabetes SharePoint page, which you can access, which is full of useful information and resources. We run a monthly online training session as well that's similar, but maybe a little bit extended version of what myself and Farah and James have done today. We've got we can do one-to-one support if you're struggling with this cohort of patients, and we're promoting the Cambridge Diabetes Education Programme, CDEP, which is currently available to everybody in South Yorkshire, clinicians and registered and non-registered clinicians, NHS staff. Which is a really good diabetes education programme. We've got free access for 12 months if you want it. I'm going to put a link up for that later on. We've also got a South Yorkshire Diabetes Quarterly newsletter, which is a really good thing to sign up to. If you sign up to it, if you contact Amy, our support officer, she can get you on the mailing list for that. I just wanted to flag that there is an Ardens template, a bit on the Ardens template for diabetes, which is a tab specifically for younger onset type 2 diabetes. I think they've actually changed the wording on that tab since we pointed out that maybe it should have the age on, and I think now it says 18 to 39. And I just highlighted there's a little box you can click on, which will give you a bit more information about that cardiovascular risk that I was talking about. And you'll be pleased to know that coming soon, there are actually going to be some guidelines. They're so close to being ready, but unfortunately they weren't ready for me to share today. But there is, you may have seen some materials going around about Diabetes Education Day on the 6th, I think it is, of December, where Dr. Soon Song is going to be launching these guidelines. But basically it's a wonderful and very comprehensive set of guidelines and algorithms, all about looking after these patients and all aspects of their care. So that will be really, really helpful for us. I'll just click through those. And then we've got this resource, which has been also made as part of the T2DAY programme, which is a website, a page on the South Yorkshire ICB website, specifically aimed at younger people with type 2 diabetes, called Your Diabetes, Your Journey. You can access that using this QR code if you want to have a look at it and refer your patients to it. And it's been, as I say, specifically tailored to cater to those people, but anybody with diabetes might benefit from it. That's just a little bit about the Cambridge Diabetes Education Programme. There's a QR code there. I really strongly encourage everybody on this week, which is Diabetes Awareness, World Diabetes Day on the 14th, that's tomorrow, isn't it? To maybe just, make a pledge to sign up to that, just refresh your education. It's got education suitable for all different levels of expertise. So from your receptionist or your healthcare assistant or care coordinator, maybe, up to specialists and specialists, doctors, nurses. So yeah, it's really worth having a look at, and it's little bite-sized sort of modules that you can jump in and jump out of depending on when you've got a bit of time, and it will save your work. So you just have to put in the code South Yorkshire at the registration page and you'll get free access for 12 months. This offer is only going to be available until February, I think, for signing up. So I really strongly urge that you do it today or this week if possible, just so you remember to do it before it goes. And then we've got this resource, which is called DigiBeat, which is for your young patients with type 2 diabetes. Again, it's a really good resource full of information. It's got education, it's got little animations, videos. It's got things that they can track their food diary, goals, things like that. And it's all been designed to be sort of more geared towards the younger person. However, might be good for learning disabilities patients. Some of your older patients might want to use it. And all you have to do is give them this clinic code DVIKG, and they can get free access to the app. So encourage you to share that as widely as you can. So that's just a reminder about our team and our contact details. If we can be of any more help to you, please just get in touch. Amy at the bottom, as I say, if you want any more resources, if you want to be on the diabetes newsletter, which is a really good source of information, I would encourage you to do that. So if we're going to think about, what might you be able to do this week about this while it's fresh in your mind? We're all so busy. There's so much to think about that doing something quickly is usually a good way of ensuring that it gets done. See if there's anybody that can help you search for these patients, be it admin, care coordinators, anybody like that. Other colleagues that should know about this? Should you be talking about this at your clinical meetings, at your huddles, passing it on to GPs, PAs, healthcare assistants? And when might you be able to share this information with them? If you feel like being a T2DAY champion for your practice or for your primary care network, and all we mean by that, we're not giving you a huge job, literally just to be a link for us, a contact for us, and maybe just take it on your shoulders to check once a quarter if they know that somebody's done the search for these patients and is looking at whether they're getting their key care processes done. So just to try and be responsible. And obviously you can put this in things like your continuing professional development, your revalidation. It's a good little quality improvement project. So, you can gain something out of it too for your professional development as well as helping the patients. So we'll see if there's any questions and answers, but I'm also just going to give you this QR code because it would be really lovely if you could give us some feedback as to whether you found this helpful, useful, if there's anything that we didn't say that we should have, or anything that we did say that didn't make any sense. Anything you want to feedback to us, that would be really helpful and appreciated. And what I'm going to do is I'm just going to stop sharing my screen so I can see if there's any questions in the chat or anything.
Someone's just asked if they could have contact details on again. Okay, I don't know if you've just seen that.
Yeah, sure. I will just go back then. So, sorry, I'm just gonna whiz back. There we go. Can you see that okay? Not seeing it yet. Hopefully it's coming through. I am sharing.
It says black screen, end of slideshow. That's what we see.
Black screen, end of slideshow. Okay. Let me just try and click on here. You seeing anything yet?
Mm-hmm.
Okay, I'm stopping sharing. I'm going to try sharing again. Share. No. Any luck?
Same again. No, same again. I'll see if I can copy it. I'll send it in chat, see if I can do it that way.
Oh yeah, that's a good idea. I don't know why it doesn't like my screen anymore. That's a bit sad.
Yeah, any more questions really, I suppose, isn't it?
Yeah, have you managed to copy and paste that at all?
Screenshot it now and put it in.
Great. So we'll get that in into the chat. Anybody? No questions. Okay, that's fine. Hopefully it made sense to you and bang on time for the next speaker. So I'll just thanks for listening anyway, and thanks Farah and James.